will join a public health expert to discuss implications of this development in the battle against malaria in Nigeria. And the program is still Health Digest, and we have our guest now in the studio. He is a public health consultant and microbiologist, Onyebuchi Eloke. Welcome to Health Digest.
Thank you very much. Thank you for having me.
Now we're talking about the new innovation, malaria vaccine. What's your assessment, first of all, about the vaccine?
All right. This vaccine started in 1987 by GSK, Glasgow Smith Line, with Army Reed Institute for Research, and that's in 1987. So then in 2001, GSK went into partnership with PATH for Malaria Vaccine Initiative with a grant from Bill Gates Foundation. So, and Bill Gates Foundation. So that was when they started funding, in 2001. Then in 2014, there is what we call European Medicine Agency, a committee there, which is in charge of products, medical products intended for human use. So went into a research to determine whether this vaccine is good for human consumption outside the European Union, which is at Article 58 process. The Article 58 process states that all medical products intended for human use outside the EU should be conducted in partnership with WHO to know whether it meets the same standard in European, that's the same European standard, since it's going to be used outside European Union. So then when they conducted that assessment, they found out that the vaccine is good and can go into further trial. So they have phase 1, phase 2, and phase 3 trial. Then the phase 3 trial was what actually proved that this vaccine is good for human consumption after doing a lot of clinical trials with some comparator. What do I mean by comparator? That's a dummy vaccine used in the clinical trial to ascertain whether these have a vaccine efficacy before introducing it to the population. The vaccine efficacy after the phase 3 trial shows 30%. That can reduce malaria 30%, according to the official from GSK. Some of the adverse events, that's what we call adverse events. Now, after taking the vaccine, the reactive, approaches at the local population. Some adverse events are rare. You have issues of meningitis, neck pains, and all that. So these things are rare. So and that will be trashed out at the phase 4 trial. But then that does not mean that the vaccine itself is not good. The vaccine is very perfect.
Now let's talk about the effectiveness. You made mention of 30%.
Yeah.
Yes, effectiveness of the vaccine. And then we know the issues we had during the COVID-19 vaccine when it was used. Even at 75%, people are still talking like, this thing is not effective, it's going to be effective and all of that. Now we have 30%. That's something to be worried about.
Exactly. That's one of the challenges that we're going to encounter when we're going to introduce this vaccine to the local population. Right now, we've not started introducing the vaccine into the population because there are so many other issues, the planning and other things need to. But I don't think Nigeria is going to have problem because the polio eradication program has given us a strong healthcare system in terms of immunization schedule, distributing the vaccine down to the national level, down to the local population. So I don't think we're going to have a problem with that. But the problem now is vaccine hesitancy and at the local population, as you have just raised now. But it's not going to be much a problem. Do you know why? Why it's not going to be a problem is that everybody in the population, especially in this country, understands that malaria is a reality for our local population. Unlike COVID-19, there are COVID-19 denialism, because a lot of people in the local population were not convinced as to the reality of the virus. Every 10 people, you point at least 4 people that said, I suffered malaria last week or last month. So that denialism is not there. The reality of malaria in our local population is there. So it is not going to be much a problem. People are accepting this vaccine because already it is something everybody accepts is
So is it a matter of accepting or is it a matter of being effective?
No, the truth is, the scientifically, the rationale for clinical trials is to attain the high level of efficacy of a vaccine. And the the clinical trial, which was conducted in 11 sites in 7 countries in Africa, showed both the phase 1, phase 2. There is even what we call proof of concept trial. Proof of concept trial is when, like you say, okay, like there's an idea I shared during COVID-19, where I told them that this virus has a compartment which makes it difficult for the immune cells to recognize that there's an activity taking place in the system. It's an idea, it's a concept. Now, for one to prove that this concept is reality, acceptable in the scientific world, you have to start with what we call proof of concept trial. So that proof of concept trial will now give you an idea of phase 1, phase 2, and other trials. Vaccine is highly 30%, 3 dose 26%, 4 dose 38 to 39% level of efficacy. So, but now when you introduce it to the real world population, that is where you will now detect the clinical effectiveness of the vaccine. Right now, everybody will not come out and tell you it is effective or not effective until you try it in the real world. Though they said in the 11 sites in the 7 countries where it was conducted, they were able to prove that it was 80% effective because it has now been tried but you need to larger population, larger outcome to be able to know that, check other events and then be able to pass a conclusive rationale as to whether it is clinically effective or not.
Now, talking about population, Nigeria is the most populous in Africa,
Sure.
and in terms of malaria, we are endemic as well. And now, vaccine has been tried in Ghana, in Kenya, and Malawi. Why is Nigeria not part of the choice?
Exactly. That is now an issue. I can't really tell you why. Because there are people, between the government, people in government will be able to say that. And the choice of those who decided where sites they will choose for the... And another thing is people who are willing to give out, volunteers, where people are willing to volunteer to, be used as a tool for this clinical trial. So these are the factors the players, those who decided where, those who made that decision, actually, those who started the trial, who started the research. So, and the government in Nigeria at that point in time, I know they must have passed some circulars and all that. So, but it depends on those who might not want to risk it. We don't want to risk our citizens, and because this is a health security too. So when you risk your citizen and it backfires, there are also some legal actions that could take place. So some governments might want to draw back to be used as a pawn for that. So it's political somehow, and then it boils down on the people carrying out the research and the government of the day when that decision was taken. So there are so many things you put in place actually.
What would you say about malaria eradication program in Nigeria? Do you think this vaccine will kind of put a stop to what we already have on ground to prevent malaria?
No, it can't put a stop. It definitely can't. It's a Swiss cheese model where you layer interventions with other protocols so that each will cover each other's gaps and then give you a maximal protection. What do I mean by that practically? What I mean is very simple. The vaccine gives you only 38%, 26 to 38% protection, depending on how many doses you're giving out. Now, there are other seasonal prevention protocols like insecticides, treated nets, vector control, improved sanitation, cleaning of improved sanitation like cleaning of gutters and all that. Like in the local population, closing those crevices where cracks in walls, where those mosquitoes, enter. These things have been giving us an improved protection for decades now, up to 75%. So imagine when you now introduce vaccine to the protocol, we will have an improved. Now, what the vaccine is going to do is not going to substitute these protocols. Rather, it's going to be an add-on to this protocol to give you an improved protection at the local population. So those places where there are gaps, delivery gaps in terms of infected nets, now, and it's even going to happen. But I keep telling people, healthcare program is dependent on two factors: political factor and technical factor. The technical factor generates evidence for the political factor to drive policies. Now, those prevention protocols we have been using, like vector controls and all that, have been helping us. So what the vaccine is going to help you achieve is those places put your money into, those places where the delivery of other protocols have reached its maximum level, where if you put more funding there, it's to waste of funding because they cannot give you any more achievement. You deploy the vaccine there. Those gaps, like those who are displaced people, where you know infested, you have spent a lot on infected nets, so you can deploy vaccine there. Vaccine will give you another maximal protection there. Then those hinterlands where delivery is highly expensive, you can deploy vaccines there through the national immunization schedule. It will close some gaps there. Then those people who are migrating, like the herdsmen, they are neither here nor there. They are, because of the level of job, they move from one point to another. So if you target them on infected nets or something, you will not, when you meet them today, you will not meet them tomorrow. You deploy vaccine. Vaccine will give them some level of protection. So you see, it is a Swiss cheese model. It's a case of where this cannot give maximal, where this have reached this optimal level, you deploy this to close the gap of this. Where the vaccine cannot give you that, you continue with your vector control, cleaning of other these things. But the best approach, if I'm to advise them, is to see a way of combining these two protocols. Even where you have deployed the nets, also deploy other vector control programs, deploy the vaccine too. With that, a combination of both, it will give you a maximal protection.
Are you sure we're not going to face the same issues we had during the polio vaccine in Nigeria? What kind of recommendation will you give to government at this point?
Apart from having a strong advocacy group, a strong mobilization group that will go to the local population, create formative empowerment, we also need to have a case management, serious understanding of improvement tools, quality healthcare improvement tools like PDIA or LCS cost analysis. That's in terms of understanding, getting in touch with the people, understand the adverse events, those who are taking the vaccine. What are the adverse events they are complaining on? What are the strategic gaps you notice in terms of deployment and other issues that will come up? So those evidence that this case management team will generate, we now triple up to the National Malaria Elimination Program. They will now use an evidence, couple it, analyze it, and then use it as a way to plan the further intervention. And then they know where to put their money in, and the money will give them the value.
All right, thank you very much, Onyebuchi Eloke, public health consultant and microbiologist, for giving us an insight into the implication of and the efficacy of effectiveness of this vaccine. Thank you so much for sharing your knowledge and your time with us.
Thank you very much. Thank you.
The program